I'm so excited to highlight your work. I have a really strong interest in late effects. It's one of my first exposures to pediatric endocrinology. I have a cousin who's the same age as me. He's 3 weeks younger, and we've always joked that he was my twin brother. He's doing great now. We're almost 40, but had ALL in the 80s. And so they love their intracranial radiation in the 80s, which means that he, got a lot of pituitary exposures when we were 3. He ended up having growth failure when we were 10. And so we had to go through that whole kind of discussion as a family. And I remember talking about cancer risk and what do we do, all those kinds of decision points. And then he went through treatment and it did everything it was supposed to do. I sought out some of those opportunities. Can you tell me a little bit about what kind of drew you over to late effects?
When I was a resident, I got really interested in the science of oncology and transplantation. But then I had a patient pass when I was on call, and I knew that I couldn't do it as a career. Then I fell in love with endocrinology. In my endocrinology fellowship, my clinical mentor ran the Endocrine Late Effects Clinic, and my research mentor was actually an oncologist who worked with immunotherapy. So that's what my research was. My husband is a pediatric oncologist, so it's really convenient to be able to have an oncologist on speed dial and be like, hey, what does this chemotherapy agent mean? And what kind of, what category does that fall in? Right. So I feel like a lot of personal connections, preemptively screening and providing this multidisciplinary care, we're able to help these patients live a relatively, it's not a completely normal life after what they've gone through, but we do what we can and we make a difference. So it's pretty awesome.
How early in the process are y'all getting involved? A lot of times these children will go through therapy and they just make all these decisions, and sometimes with good guidance, sometimes without. Then we come and get involved after the problem has progressed for a long time. So, and that depends, I think, very much on the center. But when do you think is a good time for the endocrinologist to be added to the care team?
That's a question for the ages, right? Currently, the T guidelines do recommend that you should start screening at that 1-year mark. And that's when patients get referred to survivorship clinics. I think the advantage of having a dedicated clinic and being that point person is that even as these kids when they get diagnosed, we're establishing that continuity before they get to that survivorship stage. And that's really important, more so in, kids who have relapse, right? They had a relapse a year later. At that year, it does make a big difference to have that sort of collaborative care and being able to have those channels of communication open. It's definitely been very insightful.
So where do you think are our biggest opportunities as a discipline, as pediatric endocrinologists, to improve our care for these patients? Where do you see as our biggest kind of frontier, the next big thing that we need to be considering?
This field is changing as we speak, as our excellent oncology colleagues are working on making treatment more focused and prevent issues. But then we're also seeing some of these new therapeutics with newer endocrine late effects. I think the biggest thing we can do as endocrinologists is stay on top of it, being involved, and try to identify these trends sooner than later and start managing them and preventing any clinical effects from endocrine issues. So if we could get to that point where we know that this kid is getting this therapy, that's when we would expect these things to happen, which is really, really difficult to do. If we could start predicting these things and anticipating these things more, it would make such a big difference in these patients' life. Once again, it comes down to having that team effort with oncology, because a lot of times these diagnoses will get missed because the oncologists are screening, but they might not be familiar with all the nuances of endocrinology.
Right. Just to keep us a seat at the table. I think that's important. Be in the room where these guidelines are being written, make sure that our trainees are exposed, and just claim our space here and say, yes, you're going to help them survive their illness, but we're going to help them the rest of their lives to make sure that we're optimizing everything in their health so they can have their best quality of life. Now, that's everybody's shared goal. What are the most common complications that you see as an endocrinologist?
We are seeing a lot of the same complications that are consistent with the rest of the available data. We see a lot of primary gonadal failure, which is most kids who do undergo cancer treatment will get alkylating agents. So we see that quite frequently. Short stature is fairly common. We're seeing a lot more metabolic effects. Maybe COVID has something to do with it, but we're seeing a lot more. Low bone mineral density, which is a topic that endocrinologists love to talk about at various platforms.
Talk about an impact on quality of life and making sure that those concerns are addressed. Tell me a little bit about fertility and alkylating agents. What do we have to offer, say, a boy who comes in who has had exposure to alkylating agents? If he's post-pubertal, is that a conversation you want to have before therapy starts? How do these considerations differ? I know that's a very open-ended question, but and the answer is going to be different for boys and for girls. But what things do we need to know that are available to our patients to make sure they have had these conversations and have thought through them? But a lot of times around our little boys and girls, we don't even think about 15, 20 years down the road when they want to start having a family. And we don't want to think about even like them having sex or having the sexual development that will lead to them being parents. And so we don't even uncover some of those questions. If somebody's coming to your clinic, what are the options available to them and how have these changed over recent years?
I think all patients are counseled about fertility preservation and diagnosis. But that's not really a time, like you mentioned, that people are thinking about fertility. Right. At that time, you're not thinking about, well, 30 years down the line, do I want to have kids or not? The question is, I want to live. So I don't think when I see patients in clinic, I don't think a lot of them even remember being asked that question. And that's fine. I know there's a lot of information being offered to them. And for younger kids, TESE is an option versus sperm preservation is an option for teenagers or post-pubertal individuals. But I don't think the rates of people taking up those options are really high in our institution as yet. We're working towards it, but I think for the most part, when these kids are in remission, and I do see them in that survivorship clinic, when we're focusing on thriving, not just surviving, I think that's when these things come up. And a lot of times, even a teenaged boy, if I ask them in clinic, hey, do you want to have kids when you grow up? And the answer is no, I don't want to talk about it. But having that open communication with them and letting them know that it's okay for you to think about this at this age and asking them open-ended questions, identifying what their priorities are in life and then guiding them accordingly, that's definitely a priority. So yes, I think we could do a lot better than we're doing right now with fertility preservation, but there's a lot of things ongoing.
Well, there's a lot of fires at once. They remember so little of what they have at those initial meetings. In a trauma response, they're in shock a lot of times. I'll have people say, well, you never told me that. We'll talk about sick day management, and then they'll get sick 3 months later, and they're, oh, nobody ever told me that. I know, I remember telling you that, and we wrote it down. And and even though we think we do a good job with this, we have to keep in mind that you're meeting people on the worst day of their life when they're having this traumatic diagnosis for their child. And so tell me a little bit more. So we talked about boys. What about for girls that come in? Are there options getting better? When I was in training and thinking about these questions, there just wasn't a lot on the table for girls. And people would talk about, oh, we'll freeze our ovaries and we'll freeze our eggs. And the technology is not as great as people think that it is. Has this gotten better? And what is there available to young women who are coming to your clinic?
So I definitely think oocyte preservation is an option. Once again, that is offered at diagnosis. I do think that the rates of girls asking for it or families, especially if it's a teenaged girl wanting to do this, is maybe a little bit higher than what we see in males. But again, the pressure of, are you going to wait for the next 4 to 6 weeks and do this versus are you going to start your chemotherapy sooner? The other big barrier right now is insurance, because insurance does not cover fertility preservation. So all of this has to be out of pocket, which means that there's only a certain percentage of our patients. We're in Los Angeles and more than 75% of our patients are publicly insured. A huge proportion of our patients are Hispanic who don't even speak the same language. So I think in terms of providing resources to our patients and communication, that is a priority at diagnosis. There are patients where, in collaboration again with reproductive endocrinology at the University of Southern California, we would sometimes, what we would do is we would put them on puberty suppressors during chemotherapy, which again is debatable. There's mixed evidence about that. So we would have that conversation with patients. But there is thought that that sort of temporarily puts your ovaries on pause and prevents maybe some oocyte destruction. So potentially a higher chance of us being able to proceed with oocyte preservation. And a lot of my patients would go to the endocrinologist 6 months after chemotherapy and still have the options available to them. But I think from a purely hormone screening standpoint, we do check AMH levels annually on our female patients who did undergo either alkylating agents or radiation to the abdomen pelvis. And then based on that, we would sort of direct our counseling as well.
And then you also have conversations about contraception, because when you have variable fertility in a teen, I've seen kids before who were told, oh, you'll have trouble having children, and then they have no trouble, and then they have surprises. And so is that part of your conversation as well? It's kind of interesting to have a conversation out of both sides of your mouth, but is that something that you talk about in your clinic as well?
I definitely try. We have a lot of information to cover in clinic as well. So we could probably do a little bit better on that front, but I think when we're having that conversation about fertility, we do make it a point to mention that, yes, there's a really high chance of issues with fertility, but that doesn't mean that conversation with our patients definitely is important. In those situations, it does happen, but I think we need to be talking about it more as well in terms of talking about contraception at more appointments, which we're working on.
We need to do that in all areas of endocrinology. We need to do it every opportunity that we get. Kids are told a lot of times that they'll have fertility difficulty, and we don't always do the best job of making sure that they are having planned pregnancies and are becoming parents when they are ready. I'm very curious about some of the new immunotherapies and checkpoint inhibitors. And we're seeing, especially in our adult colleagues, they were noticing a lot of the pituitary and adrenal effects of some of the melanoma treatments. And what are you noticing with immunotherapy in kids? Like, which ones are being used frequently now, and what are the downstream effects that we need to be aware of as endocrinologists?
Immunotherapy is definitely coming in, and maybe we're starting to see it now, but my prediction is 5 years down the line, that's basically what late effects will be. That is something that we're talking about a lot in the survivorship world, and then we're trying to identify those risk factors as well as we go. But the one thing we know is normally our body uses those immune checkpoint inhibitors to prevent an immune reaction against our own body, or immune checkpoints to prevent immune reactions against our own body. And those inhibitors actually allows our body to say, hey, T cells, you can now go kill that cancer cell because it's not something that's our own, right? So when we do that, we in turn we're opening the tap for all of the other cells in our body as well, which is why we see that higher risk of autoimmunity. We do see definitely a higher risk of hypophysitis or autoimmune pituitary issues, which is unique because we see a higher prevalence of ACTH and TSH deficiency as compared to all other causes of hypopituitarism, where we see more growth.
Bizarre.
Exactly. So that's very interesting. But then also primary hypothyroidism, like you said, there's reported cases of Addison's. But what I'm seeing a lot more right now in the literature, as well as at least one patient within our institution, where patients will get anti-PD-1 or PD-L1 and then end up presenting in DKA with new onset autoimmune diabetes. That should be on our radar as well. Yeah. But, immunotherapy in general, for example, TKIs are being used a whole lot more as well. Hormone deficiency, thyroid issues, adrenal issues, low bone mineral density. So again, it's a fantastic therapeutic. But at the same
Right.
time, it keeps things exciting for us endocrinologists as well.
Right. It has to keep us on our toes. A lot of us who've been in practice for a while, like myself, I haven't, they didn't exist when I was in training. So I didn't even know what to start looking for, except for just trying to stay on top of things at conferences. There's so much to stay abreast of. So I'm very grateful that we'll be able to get this out into the world so everybody can know. What are some of the unique challenges that you face working with this population? You already, mentioned the challenges of working with a under-resourced population. I think one thing that people forget is that when a child has cancer, that everything stops for the family. They have a big financial stress. Even if the medical care is covered, the parents aren't working as much, and so their savings can be obliterated. I've seen that even with patients of mine who've been treated at St. Jude, where everything is free and everything is supplied, still somebody has to be with a child. And so there's a big financial, risk there. And so I feel like that's something that we need to, talk about when we write this up, is the financial implications. But what other things are you seeing and taking care of these children?
Maybe the biggest barrier in my mind is this is not the only thing they have. Right?
Mm-hmm.
They have a lot of other, and even when you talk about hormone conditions, it could be a child presenting, for example, a child who got alkylating agents and total body radiation, who now has a normal growth velocity, and you examine them in clinic, but they have prepubertal testicles, and this kid's fine. But then actually what's going on is that the testicles are prepubertal because they have circularly cell dysfunction. They're actually in early puberty and making a whole bunch of testosterone that's causing their growth velocity to be high. But they also have growth hormone deficiency, or they got radiation to their spine and their vertebral bodies aren't growing. And it looks like, oh, well, their growth velocity is normal. So I think from a science perspective, the big barrier is it's easy to miss things and you have to be on your toes. Right. So again, having an endocrinologist who's familiar and who's looking out for those things is important. Another big thing, like you said, is the fact that they had cancer, they went through the toughest time ever in their life, and now they're done with it. Everyone tells them, okay, you're cancer-free, you're a survivor, you're done. And then we turn around and say, you know what, just kidding. You also have to see 5 other doctors. You have to still miss 5 days of school a year because you have to see these 5 doctors every year. Parents have to still allocate financial resources. And it's not just transportation and financial resources to get to the hospital, but also 5 days a year that they're missing work. So that does make a big difference. And as providers, I think it does fall upon us to give our patients the tools that we can. And it also comes down to, in all aspects of healthcare, we're talking about social determinants. So I think to help our patients address and identify those determinants is important. So I think the one thing that we do try to do is schedule multiple appointments, like provider appointments the same day, that they're not driving in and out of the hospital all the time. We're very flexible with converting appointments to telehealth. So if you're not able to come in, that's fine. We'll still do a telehealth visit. We'll still do the same screening. But also, I think that collaboration with the oncology team, which means that if I know I will see this patient in clinic, I'm going to start screening, whatever screening I would recommend, or sometimes even management in collaboration with oncology, even before they set foot in the endocrine clinic, which minimizes the number of actual visits they need to make to clinic. So I think, and then having a social worker in clinic is super helpful because then they know to address factors that I can't address within the domains of the 4 walls. Another, I think, going back to the science of it, another barrier, as we were talking about, is the fact that things are changing. So even if I memorize all of the COG guidelines right now, and I'll be like, okay, now I know what to look for, there's going to be a new therapeutic. There's going to be changes in the way we think about things. For example, methotrexate is something that we always have associated with low bone mineral density. But then the guidelines are now going to be changing, and we know that that's not such a high risk when you compare it to radiation or high-dose glucocorticoids. So again, you need to be on your toes and you need to be aware of the standards of care so you can provide them I think the other thing I always think about is from a clinical standpoint. You get 30 minutes to see a new patient, but they come to you with years of history.
Yes.
You
Mhm.
need to be familiar with the type of therapeutics they got, what complications they've had since then. So it does fall on the provider to sort of spend the time reviewing that chart in advance and after, and to guide and help our patients navigate. So that, again, I think has been a barrier. But then the one thing I would say, sorry, I'm like going back and forth. I was thinking about the no-show rates because,
And you're fine.
that's a huge, huge thing that anytime we have meetings in the survivorship world, that's something that's always brought up as a barrier because of all these things, right? So, like we said, patients are done with cancer, and now you tell them, hey, by the way, you could develop a thyroid issue, which we're going to test you for, but you could develop a thyroid issue in a year from now or 30 years from now.
Right.
So it doesn't feel as important to them. And
Mhm.
traditionally, the show rates have been poor.
Mhm.
But to the credit of our oncology team educating them, and to our team's efforts and collaboration, our since we started the survivorship endocrine late effects clinic in October, our show up rates or attendance rates have been 81%, which are
Oh,
pretty
wow.
consistent,
Huge.
right, with the rest
Yeah.
of our endocrine clinics. So I do think little things that we do will make a difference. So if we can go a little bit out of our way to help support our patients and also educate them, that does help address these barriers a little bit. So.
Do you share clinic space with your oncology colleagues, or in what setting are you seeing these patients in?
Right now, I am seeing them in the endocrinology clinic. But then, like I said, in collaboration, as in we still would talk and communicate with the oncology team, and they would reach out to us and communicate. So there's always that open line of communication. The goal is eventually to have a multidisciplinary clinic where patients come in and they see all the providers that they need to see at each time. But since we just started this out, we're working on one step at a time.
How would you advise an endocrinologist like me who's in the community and maybe a little bit past training? And we have a patient show up in our clinic who is asking questions and said, hey, I'm near Air Force Base. So I get people who've moved in from all over the country, sometimes with records, sometimes with not. And they show up and say, hey, I had, polycystic astrocytoma, and I was treated when I was 4. And here I am. They said I needed to see an endocrinologist. So where would somebody like me turn to, of course, I've got friends that I call it, but let's say that let's pretend I didn't, pretend I don't have your email address. Where do I go to find guidance to help patients like this?
I think if you want to look at the standard of practice for anything survivorship, I would say the COG guidelines are the place to start. But then also, I think on behalf, I will shamelessly plug in the Peds Endocrine Society TREND-SIG, the Tumor-Related Endocrine and Neuroendocrine Disorders Special Interest Group, where we're working on developing more and more educational module or sort of handouts for our patients. And we have a whole special interest group that meets every few months, and we talk about these issues and we work on developing collaborations. So if you're really interested, that would be a really great place. But pedsendo.org would be a good place if you just want handouts for your patients.
Well, what is your current area of research?
I'm like full of ideas and wanting to do a lot of things. I think the one place that we're starting with is making a registry for our patients where we have a list of our patients with diagnoses, cancer treatments they receive. It becomes easy for us to identify trends, but even going forward in the future, if something is identified, it's easy for us to look back and then again go back to the patients that would be at risk. We're working on identifying whether it is because obesity is something that is really, really prevalent in the patient population that we see. Specifically, the ALL patients that we see have a risk of as much as 6%, right? So they're already at a high risk of cardiovascular mortality, morbidity, but then you add obesity to it, plus like potential hormone issues and stuff. So their risk is really high. And I know that obesity is an epidemic. Everyone's talking about it. Everyone wants to do things about it. And in general, people are using weight management medications more. But there's almost a resistance or a fear of using these medicines in cancer survivors because these patients are not like all of our other patients. They've gone through a lot. They've received a lot of treatments. They might be on a lot of different treatments. So is it safe? Is it effective to put them on weight management pharmaceuticals? So I think that's something that we're studying, and we're also assessing provider comfort.
I'm so thankful. Anything else? So you got an open microphone to anybody who wants to read the column. What kinds of things do you wish that everybody, working in the pediatric space knew?
Endocrine issues happen really frequently in
Yes.
childhood cancer survivors. We don't see all of those patients. If you look at the CCSS data, or if you look at like the Danish cohort or the Italian transition units, about half of the patients that recover from cancer will end up having an endocrine issue. And a lot of patients have childhood cancer. The incidence is increasing over time. Right now, the incidence is, or if you're between 1 to 20 years of age, you have a 1 in 282 risk of developing childhood cancer. And I think 1 in every 500 adults is a childhood cancer survivor. So then, and then like the most recent data I saw is that in 2022, about 10,500 children will be diagnosed with childhood cancer. So if you assume that 50% of them will have endocrine issues, are we really seeing these kids in clinic? The answer is no. So I think that's the take-home point that I would want to let everyone know. There are resources that you could look to learn how to screen. Another really good resource is in 2019, Hormone Research had a special edition which was all about childhood cancer survivors. So that has a lot of many reviews that if you wanted to develop a quick like med student curriculum or something on this, that would be a really good resource as well. I remember as a new attending, the first survivorship patient I saw was actually not in survivorship clinic. That was a patient that was referred to us, who was referred to us by a general pediatrician for just weight gain. And the family had been telling this patient, you're lazy, you don't do what you're supposed to. But then when we saw them, and this patient had like transferred care to a different pediatrician. And we went into history and they're like, oh yeah, my child had brain cancer like 7 years ago. And then we found out again that this kid had hypothyroidism, testosterone deficiency, growth hormone deficiency, and all of those things.
Fixable problems.
But then also by the time we saw this child, as a teenager, they'd already had their growth plates fused. So not much that you could do. So I think you're absolutely right. Pediatricians need to know about this.
One of the things that I think we can do as endocrinologists is continue to champion these patients and keep that same kind of energy of support. Well, thank you so much for your time.